So today's lecture is going to be on eating disorder. Our objectives are going to be able to recognize the symptoms of anorexia nervosa, bulimia nervosa, and binge eating disorders, look at treatments for individuals with eating disorders, how do we apply that nursing process in caring for these patients, and then learning how to educate not just the patient but the families and the communities about eating disorder, and at the same time evaluating our own feelings and beliefs and attitudes towards individuals with eating disorders. With self-reflection, we're going to think about what we believe the ideal body size and shape. What do we think about that? How do we feel about people who might be overweight? Can a person ever really be too thin, or do I worry about my weight a lot? Do I have any biases about eating, about weight, that could interfere with me being able to care for my patient? The biggest thing is that nurses evaluate themselves. If they suspect that they have an eating disorder, they may not be able to provide the care for those patients who cannot regulate their own eating responses. These nurses really need to seek professional help for themselves before attempting to care for others, and that's why the self-reflection is necessary. So how do we relate to food? Most people, when they think about food, think about celebrations, social events, bereavement, or emotional support. What kind of food do we or you usually celebrate with? When I think of celebrations, my family, it is always fried chicken, green beans, sweet potatoes, macaroni and cheese, and a whole plethora of other things. However, you can see through some type of self-evaluation and looking through it yourself as you evaluate what brings you guys together around food. Whether it be the holidays or when we eat when we're sick. Again, when someone dies, we take food to their home. There's usually a repast. So we think about those things. When it comes to comfort food versus healthy food, where does our lifestyle fit in at here? So the question that I asked you is, just think about it. What are your comfort foods? Again, my comfort food is mac and cheese. I love sweet potatoes. But anything that makes me really feel good about myself, and on a really good day, right, this next one, I can just delve right into it. That's right, Dairy Cream Corner. When I'm really I can go down there and have me a really good time out. But what does it mean to you? Chips, this is my Super Bowl time. When I look at these pictures, I know that you see a conglomerate of food put together. But when I look at this, I see comfort foods that I'm accustomed to because I'm from Maryland. So whether it be 5-piece wing and fries, a fish and fry basket, pizza, subs, Chinese food, you name it, it's in there. Those are the things that I was brought up on, and that kind of brings me a little bit of comfort. It reminds me of home when I have that kind of food. But people relate to food differently, and it's not always in a good way. So at one time or another, we may have overeaten or skipped a meal. But when we start looking at how it can affect someone, especially adolescents, and their perspective of food, their thought process, even how we manage food and how we deal with it. Men, they burn more calories. And so, but as they get older, they begin to gain weight. Everybody's response is going to be different. However, when it comes to eating, it can become maladaptive due to not having an ability to cope. And as a result, it turns into an eating disorder. So couple of the eating disorders that we're going to talk about throughout this lecture include anorexia nervosa, bulimia, and even in this picture, it talks a little bit about pica, and I put that one in there because you will see that come across in your testing and it has C, but I wanted you to know that it's there. Some additional things that we're going to talk about is night binging as well, and how eating disorders can consume a person's life, and they can only come out of it with that help, that professional help. So with eating disorders, what's important to understand is that that it usually arises out of an anxiety response. So it will be either at one or the other spectrum of either eating too much or not eating at all. You'll find it most commonly amongst white middle-class adolescent girls and women. It's becoming, though, more widespread to be encompassing of all ages and sex and races. It was first identified in the 1960s, along with bulimia being identified in 1970s. And as I mentioned before, even now you'll see it not discriminate against male or female as well. The identification of anorexia and bulimia first came up in the time that it did over this overwhelming pressure to meet this idea of what a female should look like. So a lot of the times that came up with when you started to see models. And so there was this perception of, if you like, associating being beautiful or being successful to how you look. So this thin culture evolved, and it's the idea that the more intense the social pressure is on a young woman to be slender, the more likely it is that they'll develop an eating disorder. And so what happened during that time is many of the women would try to control their diet to maintain the admiration, and then to also have that appearance of being successful, and that they had achieved something, and to have self-sufficiency. And this did not discriminate against any race or social class. It was amongst all the social classes. In the U.S., women are becoming heavier, while the ideal weight is portrayed as thinner. And if you have any idea why, let me know in class. More than 50% of American women say they're on a diet, and in a recent survey of 5th to 8th graders, 31% stated that they were dieting, 9% said at one time or another they had fasted, and 5% had deliberately vomited. Not good at such as a young age to really be in that mindset, because the longer they go in this I guess their identity of themselves, to be so young, to be thinking that, you can only imagine the detriment as they get older. With anorexia nervosa, this one is a fear of obesity, feels fat when they're thin, loss of at least 25% of their body weight, refusal to maintain minimum body weight, and they may have amenorrhea or loss of their menstruation. So just breaking this down a little bit, that absence of hunger, they really are obsessed with food as any starving person would be. They just aren't eating. Signals within their body, things that they're thinking subconsciously, is things like they'll take up less space if they're small, or that if the smaller they are, they won't be in the way, or the need to stay this little girl, or lacking the desire to want to grow up. These are some expressions of some patients who've had anorexia. In early adolescence, girls surrender their attitude about their bodies. They become really self-critical. Especially hard for them is the fact that they're going through a critical time in which their body's already starting to make changes hormonally, including their hips becoming rounder or fat cells beginning to enlarge. And so they begin to think of their bodies as something others would judge. So they, as a result, they end up developing an eating disorder. And remember that this is a way of thinking. They're thinking of their bodies in ways that they think others are judging them. And then they're also looking at how they appeal to others, making that the focal point of what matters. So because of that over concern of what other people think, then it becomes the main focal point. Signs and symptoms that you're going to see include dry skin and hair. They're going to have cold hands and feet. They can have heart irregularities. They can have complaints of dizziness, anemia, constipation, slow heart rate, low blood pressure, body temp, fatigue, lethargy. Just kind of think about that a little bit as to, you see these signs and symptoms, but what are these heart irregularities and why are they having these heart irregularities? Is it because of their electrolyte being imbalanced? Could it be the malnutrition that they're going through as the cause of anemia and constipation, slow heart rate, and heart irregularities? These are the things that you're going to be thinking about. Majority of the time with anorexia, you'll see that start to present itself at around the age of 13. And then it begins to take on its own life. And because of the young age, because of the severity of this eating disorder, there's a higher rate of fatality. It's that obsession with the weight, and they become very rigid in their thinking about food. So some warning signs. Again, we talked about a loss of 25% or more of their total body weight should make us concerned, especially when there is no apparent cause. That's your red flag. And then as you do your assessment, if you sense in them that fear of gaining weight, if they haven't had a period, and that usually happens when they've lost about 10% of their body fat, exercising in excess despite being tired, if they, of course, going to be in denial of hunger, or if they're handling their food in such a way that says that it looks like they're eating but they're not eating. So you pay very close attention to that. Other things to remember, just keep in mind again that onset happens between the ages of 13 to 20, that anorexia is 10 times more common in women than it is men. Weight loss leading to body weight less than 85% of the expected weight, or decrease in weight by 25%, is a red flag. And failure to gain weight during growth spurts with that ideal body weight less than 85% is something that we should signal that this person might be anorexic. So what are our goals? Our goals are going to be to reverse weight loss. We're going to take a dual focus approach. One, we got to make sure that physiologically their nutrition is taken care of, and then we can take a psychological approach. So with their nutrition, we want to make sure that we're getting their ideal body weight back to where it needs, and so as a result, we're gonna put them on bed rest. Why do you think that is? To conserve their energy. We have to make sure that they're physiologically stabilized, so we're going to be looking at their electrolytes, encouraging to eat small amounts of food, and then when their weight gain occurs, that's when we can start taking care of them psychologically. Remember what we said, taking care of physiological needs first. Once they have begun to gain weight, then we can talk to them psychologically and help them in that mind process. Medications that we might see them on include SSRIs, which are antidepressants. Examples of those are Prozac and Zoloft. With psychological treatment, we're going to have to help them learn more effective ways to cope, how to express themselves about their body, enhancing their body image to be beyond what they think others might be thinking, and include their family into the treatment. Here we have bulimia nervosa. This is when a person binge eats. They usually do this in solitude. They may vomit when the binge is over, and they usually sleep after eating. We're going to go into this though just a little bit further in our next slide. So eating binges are usually followed by a purge, what we kind of seen a little bit in that depiction in the previous slide. It is more common than anorexia. 4 to 15% of females in high school and college students between the ages of 15 and 18 are affected by this. And the earlier the treatment, the more successful it is in helping that individual. Some of the things that you'll see that they'll use include laxatives, self-induced vomiting, enemas, purging without binging, and over-exercising. Of the most common eating disorders, it is also most common in young women. And it starts with a desire to want to try to control their weight. And as a result of that fixation on trying to control something, it kind of takes on its own life, and then it becomes a preoccupation when they're eating, purging, and then looking at their weight. And when you look at your patients with bulimia, they're really not thin. They're really maintaining. So they're usually right within that range. But like any addiction, it can become compulsive, and as a result leads into destruction of their own life. And when I say that, just especially socially, but also physically as they progress on in this eating disorder. One of the things that we try to help patients see that it takes 4 hours for the stomach to empty food and 4 days to eliminate it from the body. So when they go to binge and purge with laxatives, it's not really getting rid of the food that they just ate. And vomiting only takes the top quarter of the stomach. So when it comes to purging, and it really isn't beneficial to them. So you will see some personality changes with the eating disorder of bulimia. They'll love binging more than anything and become even more obsessive and secretive. They feel guilty about what their behavior is, and as they begin to experience loss of control, that will lead to depression. They can have irritability and be withdrawn, especially from their family members. And since when they come into the hospital, majority of the time they are with their family members, it's important to ask family members if they notice any behaviors that may be out of the norm for the patient, and then keeping these personality changes in mind. And the reason why we're vigilant when it comes to doing our assessment is because the earlier the treatment, the better the outcome will be with both anorexia and bulimia. With bulimia, what can be more fatal is the gastric dilation that can lead to rupture as well, along with electrolyte imbalances that can cause cardiac arrhythmias. They can have ruptures on their face and necks and calluses on their fingers and thumbs. They can even develop cavities as it relates to the gastric acid from the emptying of their stomach contents into their mouth. So we want to be making sure that we're also doing a thorough assessment to see if we see any of these characteristics. And I got a little bit ahead of myself there, but there you go with the fatal complications that can happen as a result of bulimia. With the electrolyte imbalance, we're thinking about that hypokalemia that can cause that cardiac arrhythmia. We talked about the broken vessels in their faces and the calluses. Later on into their adolescence, as they move forward in their development and age, you'll start to see that they may take on this with them into their next level of education. So a lot of the times you will even hear of bulimia being a college girl disease, being denoted as them being impulsive and out of control. A lot of the times, because of not having a coping mechanism, these individuals become vulnerable to substance use disorders. Not so much alcohol because of the calories, but they find other substances to abuse. You'll see them when it comes to bulimia, size and shape that is going to vary. In their mindset, they're just wanting to please people. They want to be attractive. They want to have that good social skill. They want to be included. They want to be involved. And the truth is I think what happens is in their mindset of what they think they should be, and trying to be that, they end up it ends up taking over their lives, and they really lose themselves within this disease. Psychodynamic theories says that the cause of eating disorder is caused by a disruption in the development of a really good healthy defense mechanism. As children, they're very self-critical, and it could also be something that they also get from their parents. Self-indulgent met with self-deprecating thoughts and feelings of worthlessness can be behind this. Their body becomes their enemy. They become preoccupied with hunger or that fear of lost control. And these are the psychodynamic models. Other theories are about the mother, the complex that comes from mothers, as mothers are preoccupied with their own weight, dedicated to fulfilling the needs of the family, feeling a need to present what people want to see. Food becomes then a conflict between the mother and the child, and now the child wants to have some control, and overfeeding and underfeeding is based on what the mother's feelings are. Food becomes a conflict between the mother and the daughter as a means of control, and as a result, the child ends up developing their own complex. There's also some thought that there's a correlation between early childhood sexual abuse and bulimia. So in essence, what you want to get from this is, and for an example, a mother who was overweight and realized that she wasn't realized for herself, maybe because of what other people thought or a comment that was said, that she needed to change something about herself so she lose weight. And in her essence to lose weight and diet and exercise, she brings a girl into the world. And then that daughter, she's like, my daughter's not going to go through what I go through. So she takes her own conflict with food and she puts that onto a child. And when you have a child who is energy and just needs to eat, that becomes a conflict. And so that child wants to have some control over that. There's a conflict that happens. And so when you see that disruption that happens between them, and especially in the mother-daughter relationship, it can carry on for that child. And as I mentioned earlier in this PowerPoint, when it comes to children, that prolonged amount of time having a low self-image or low self-esteem can be detrimental. Other theories include sociocultural models that said there's a cultural acceptance that slimness is a current thing, obesity is rebellion. In a biological model, there's still some research trying to make that connection between eating disorders and depression or genetics. So we've taken all that in. We've looked at all the information. We've got an idea of the fact that with all the eating disorders, we're looking at the characteristics that can put them at risk first physically. So when we're doing our assessment, we're checking their weight. We're checking how they eat. What's their diary? What did they eat for the past couple of days? What was their activity like? What's their family history? Then we're going to start looking for physical signs and symptoms related to anorexia or bulimia. We're going to ask them about their anxiety, letting us know what brings them the most stress, and then determining based on the data that we collected whether or not they have need for hospitalization. As I'm looking at their weight, I want to know what their present weight is. I'm going to be looking to see whether or not they had a loss of 15 to 20% of their ideal body weight. And with that, I probably would admit them. It probably requires admission. If do they have a distorted body image? What do they think about their weight? And what do they see when they're in the mirror? And how does their mood influence their weight status? Is it affected by anxiety, guilt, or depression? And then I'm going to be looking at their vital signs again based on their electrolytes. If they're using, especially if they're using laxatives, diet pills, or diuretics. With eating, when you're eating, are they have this avoidant mannerism around food? With that binge purge cycle with bulimia, there's an inability to control their impulses. So they're going to use lying, sex, drugs, or stealing. You're going to see that. Some of their activities, as far as the eating disorders, can be very compulsive, especially with exercise. So I'm also going to be asking them questions like, what was their last menstrual period? That's significant because if they haven't had it, 10% of their body fat has been gone, and now I'm definitely going to be looking at them medically. What is their family dynamic like? With anorexia, patients may report their parents as being strict and controlling. There might be a perfect family complex, children having conflicting messages, poor conflict management in families. Maybe there's some marital discord with bulimia. It may be chaotic and disruptive. There might be poor impulse control, violence, and alcohol. With anorexia, some of the physical signs and symptoms, to be clear, cachexia, hair loss, yellow skin, cyanosis of the extremities, cessation of their menses. They can have peripheral edema, hypotension, lanugo, tired, and they could be lethargic. They can have anemia, and they can have heart irregularities. I'm going to say to you, as far as this slide is concerned, that there are several things on here that you need to know. Make sure that you look up your definitions. Understand what's happening. And if you have any questions, make sure that you reach out. The way that I will look at this is the fact that that they have cachexia says to me that they're malnourished. If they have lanugo, their body's using it to help them maintain their heat. If they don't have a period anymore, they've lost too much body fat. If they are tired, they don't have that energy. If they have heart irregularities, there's an electrolyte imbalance. So looking at all those things that's happening and explaining why they're having those signs and symptoms and what's actually going on in their body can be very helpful. With bulimia, they're going to have frequent vomiting. They can have parotid gland enlargement. They can be hoarse, have dental caries. They can also have electrolyte imbalances. They can use substances to help them purge. They are going to be in need to be closer to their weight or slightly over. They're trying to maintain that, and they may have esophageal tears. Some of the nursing diagnosis, most importantly for me, is that altered nutrition that's less than their body requirements. But other nursing diagnoses that you will see is that ineffective coping. They have a high risk of self-harm, body image disturbance in their self-esteem, and chronic low self-esteem. With inpatient treatment, our goal is just going to be to reverse whatever's happening with them. So with anorexia, it's going to be to reverse the weight loss. It's going to be, again, a dual approach. We're going to be looking at new nutrition, getting them rehabilitated, and then we're going to do psychotherapy. We're going to help them do some behavior modification. So where we emphasize weight gain, They're going to have regular weigh-ins. They're going to have passes and privileges once they start gaining weight. And then we're going to be helping them enhance their body image. With bulimia, the goal is to interrupt the binging. So we're going to reestablish a normal eating pattern. Let them have an exercise plan. Help them learn ways that they can engage in coping. With that, they may need assistance with anxiety because they're going to feel like they're losing that control. So medications that we're going to use are SSRIs, antidepressants, Zoloft, Prozac. The only thing is caution with anti-anxiety medications being used because, again, they have more of a risk of a self-harm, especially with depression, and so we don't want them to use that medication to harm themselves. And they may be the ones that will abuse alcohol or drugs. Now, with both of them, there's a substance use disorder component that can go along with them. However, less likely for alcohol to be used in anorexia because of calories, more likely to be used in bulimia because that's not the concern. With education, we're going to be talking about the effects of having a good eating pattern. We're going to be talking about educating them on weight regulation, on the effects of starvation, and the effects of bulimia on their health. It's also important that we help them identify what their triggers are, especially working hard with them if they have a career that requires that they maintain their weight. Understanding that the patient, whatever treatment plan that we do, patients have to be involved in it and have to identify and agree with the problem that presents. If they do not feel they have a problem, then anything we do for them will not have the lasting benefit that we want. And then once they agree that there is a problem and agree to participate, then they're a lot more likely to be successful. Nursing outcomes, you can see those in your book. Obviously, there are several. We want an undoing. We want their fluid electrolytes to be stabilized. We want their heart rhythm to be where it's supposed to be. Ideally, we want them to have an ideal, maybe back to an ideal body weight for themselves. We want them to have high esteem for themselves and overall, and have a good overall health. Other eating disorders include binge eating disorders, which is eating binges and then there's nothing equal gaining weight. With obesity, they're overweight, and overweight as they get older and they just keep putting on weight. And then night binging is binging based on endocrine, circadian rhythm changes, insomnia, and nighttime awakening. And I just threw that in there because this information does show up when you're hustling. And that almost concludes our lecture. Be sure to watch the Watch and Learn in your Lippincott. And if you aren't able to click on this link, you can put it in manually. Actually, if you go in and you look under videos or go underneath your chapter, the Watch and Learn will be right underneath there.